we're joined this afternoon by Dr. Thorsten Giesecke, who is General Manager in Commercial Business for Janssen Sciences Ireland. Derek O'Keefe is a consultant physician at Galway University Hospitals. He is also an engineer and Professor of Medical Devices at the University of Galway. Roisin Shorthall, TD, is co-founder and co-leader of the Social Democrats. She is the party spokesperson on health, and she chaired the All-Party Committee on Sláinte Care in 2016. And Dr. Philip Crowley is National Director of Strategy and Research at the HSE. And you're all very welcome. And I'm going to grab my iPad there because thank you very much indeed, Derek. Because I want to get your questions again on Slido for our panel on this topic. So Roisin, I'll start with you, and if you would link for us the rising cost of living, the fall in living standards, what it means for our healthcare system.
Okay, I suppose I'd first, Audrey, like to speak about what it means for people who are impacted by it, and then as a result of that, the impact on the healthcare system. And we know that the social determinants of health are critical in relation to demand for healthcare and pressure on healthcare systems. And very often what we see then is in those areas that have the greatest levels of deprivation, we have what is known as the inverse care law applying. So those areas where there's the greatest health need are likely to have the poorest healthcare provision. And I think we see that across many, many communities right across Ireland. So the latest figures in relation to enforced deprivation were 2021 figures, and that showed that almost 14% of Irish households were living in enforced deprivation. Now, if we consider what has happened since 2021, obviously the impact of COVID, but as you said, Audrey, the impact of then world events, specifically in relation to, I suppose, events arising from COVID in relation to supply lines and so on, but also then more specifically in relation to events early last year with the invasion of Ukraine and the impact that and other factors in this country have had on the cost of living. So the likelihood is, we have to wait till May to see the latest figures for 2022, but the likelihood is that that figure of almost 14% will have gone up very substantially. And what the 14% figure represents is about 690,000 people living in enforced deprivation, and that includes about 200,000 children. So we're going to be talking about a figure close to €1 million, a million people living in enforced deprivation. And that, of course, will put huge pressure on people's ability to access healthcare and, in turn, pressure on the health service. So I think where we'll see the impact of that is in terms of people having greater difficulty really across the board in affording out-of-pocket expenses to access healthcare. And then, in terms of the private sector, I think we will see more people considering whether they're going to be able to renew their health insurance. And, for example, VHI have said that from March this year, insurance will be going up by about €250 per family. And that may well be the straw that breaks the camel's back. So I think we're going to see the impact of the rising cost of living right across society in relation to raising problems with access to healthcare. And then there is also that issue about impact on quality of life and, healthy food, for example, that kind of thing. And we saw Bernardo's this morning issuing a statement about surveys that they've done, showing that I think it was 29% of families have concerns about their ability to provide enough food, basic food for their children. And that then raises issues about quality of food and healthy food and so on. So I think we are going to see quite a significant impact on the health service in terms of greater demand and other factors associated with that.
Thanks, Roisin. And Derek, do you agree with that, just purely from a medical point of view? If there are 690,000 people in enforced deprivation, they're more prone to getting ill. Yeah. Oh, you're not mic'd.
I might speak here, yes. So yeah. I think, yes, for sure, that's true. There's unprecedented demand on our health system. and it's going to get higher, as we heard this morning from Ronan. The demographic change in the population is something we know that's happening, and we need to plan for that, and we need to put the resources in place because we need to make it actionable. So I think forums like this are really good to highlight these issues. It's great there are some clinicians here to be aware of what's going on operationally, but yeah, it is going to be a massive challenge, and it's something that we're going to have to plan for and put resources in place.
Thanks, Derek. We'll get a mic for you. Thanks a million. Philip, what's your view on this? How is the HSE planning for this?
Well, I think we would all be very concerned about inequalities in economic well-being, because that clearly, we know very well, there's massive evidence base to show that economic inequalities lead directly to health inequalities, that people who are poorer, as Roisin has said, have less access to the kind of tools to live a healthier lifestyle, and therefore that deepens again the inequalities that they will experience. And then economic deprivation harms your health in all kinds of ways. It harms your health mentally, it harms your health physically. We've seen in some of the recent data, which I'm sure we were all very shocked at, to see the number of people who had in Irish society considered ending their lives. I think we cannot underestimate the impact of the pandemic on all of this as well. And then add to that the rising cost of living. I think we need to act to reach out to communities that are, and we are doing that work to try to address these inequalities.
And what does that reaching out involve? What does that look like at the other end?
Well, I mean, obviously, I can't speak for the entire health service because an awful lot happens locally at local community level. We have services embedded in communities right across the country. But nationally, part of what we're doing in as funded by the Sláinte Care Healthy Communities Programme, which has been a fantastic support for this kind of work, we are reaching out into the most deprived communities and working with local community organisations and local people in the communities to address issues of access to health and well-being directly there in the community.
Thorsten, what's your view on this, on that link between the rising cost of living, which is one of the main crises facing so many people around the world, but in this country that we're talking about, and healthcare and the quality of their healthcare and the quality of life?
Yeah, so I want to make a case, I want to say a little bit for investment, for continued investment in healthcare, because COVID actually was a situation where everybody needed to pull together, and it was great to see this morning in a presentation for advanced algorithms how during COVID actually a peak in performance of the healthcare system happened. So the healthcare system performed actually during COVID much better than after COVID. And this now with the rising cost of living, and of course it's a difficult decision for politicians to make. People need housing, people need food, but people also need healthcare, where to invest. And there's a lot of austerity measures that we're observing right now. So basically we invested massively into healthcare because we had to. Now we're pulling this back out. And that is, I think that's the wrong reaction because I mean, we don't even have COVID behind us, but now there's RSV and there's flu, and the lines in the hospitals are actually longer now than they were during COVID. So the investment in healthcare actually should continue, and we need to build a more resilient system because this continuous firefighter mode, that's what's burning people out. If we can build a more resilient system, and there is a white paper coming from the World Economic Forum this year that actually says for every euro that you invest in a resilient healthcare system, it can generate up to €4 in return. So it's actually even a viable investment. Actually, if we look at healthcare not as a cost, but as an investment, that could be a good argument to say, let's continue to invest in healthcare, let's build it, and let's build capacity. Because the one thing, I mean, it's been a lot of talk this morning about the room for improvement in the healthcare system. There are long, visible waiting lines of patients on trolleys. There's also long, less visible waiting lines. That's patients who don't have access to innovative drugs. And when I came to Ireland in 21, I learned about those people here at my company at Johnson & Johnson who make drugs for the rest of the world, and they're being distributed to the rest of the world, but they're not accessible for the patients who make them. And that is something that I still don't really get my head around. So that's another waiting list for me that should be addressed, and that requires additional investment.
Philip.
And maybe adding to Thorsten's kind of call for investment, obviously we're always looking for more money, aren't we, I guess, but that's because we care about the services. But one of the things I really think we need to continue to deepen our investment in, we've seen a fantastic drive in that regard over the last number of years, is in prevention. Because if you're talking about the economics of healthcare, the best healthcare is no healthcare at all, because I don't need it. So I've had the supports, I've had the encouragement, I've had the access to facilities and whatever that helped me lead a healthier lifestyle. And I think it's like there are loads of studies internationally to show that investment in prevention pays back many times over.
Derek, do we invest enough in prevention? How would you assess that?
So I think traditionally medicine is focused on the sick. It's just the way that society has evolved. And as we're getting better and we're realising that we can increase lifespan and health span, we're realising that the earlier we intervene, the better. So we are getting better at it, and we're moving that lens away from the last year of people's lives to 10, 20 years before that, to manage and even prevent the chronic diseases of diabetes and heart failure and COPD and so on. So we're getting better, and it's actually a really exciting time. I've come back from the Mayo Clinic in the last 3 years to come back and see a programme such as Sláintecare, which is putting in the resources into these chronic diseases to manage them successfully, to keep people out of hospital, healthier, at home longer. So I think we're doing that. It's a continuous journey. It's about reflecting and improving. It's not a destination, but it's great to see that lens moving off that last year or two of someone's life where all the healthcare dollars traditionally go back through the life journey to prevent that illness. And when you look at somebody's chart, it's very clear when you see it. You know, you often open a chart and see somebody got a heart attack at 50 and got cardiac stenting. In their 60s, they developed a chronic disease and needed treatment. In their 70s, they got cancer and got chemotherapy. In their 80s, they got a hip fracture and they got surgery. So we see all these points where we're keeping people alive because of better care. And now you're going to see an expansion of that as we prevent and delay those diseases till later in life. So we're doing a really good job in Ireland, and I think that should be noted, and we're getting better at it, which is quite exciting.
Roisin, I'm sure you keep a close eye on Sláintecare and its implementation. How would you assess where it's at now? Is it being implemented?
It is being implemented, but very slowly, I have to say. And what we need is a step change. Like, there are excuses, okay, that for the last couple of years or last 3 years, there are excuses in relation to the impact of COVID. But at the same time, like, the whole idea of the structure that was set up at the time in 2018 was that there would be a separate implementation office and, you know, a group of people who were responsible for implementation and who weren't getting drawn into the everyday crises within the health service. Now, we know what happened to that implementation office, unfortunately. And like, I listened to your interview there earlier with Stephen, and I do believe that the main obstacle, I have to say, to full implementation of Sláintecare is a cultural thing. And I think that has to be recognised. And unless we recognise that, I don't think we're going to make significant progress in implementation. I mean, it is a recognised feature of any change management programme that you will have institutional resistance to change. And like, unless we actually name that and put in place strategies to address it, you know, we're only fooling ourselves, I believe. And that's why I would have been quite critical of the decision to replace the implementation office with the senior people from the department and the HSE. And I made the point at the time, if the department and the HSE were capable of that kind of radical reform, it would have happened a long time ago. So we do have to change the culture, and I would say the main way that you change the culture is through legislation. You must have legally based accountability within the health service. And that is part and parcel of what is proposed in relation to the RHA restructuring. You know, we can move the deck chairs and set up 6 regional authorities, but unless we devolve responsibility and devolve accountability from the centre and make those area management teams legally responsible for the provision of services and the spending of budgets, like, not a lot is going to change. And that's why I think it's really important that that whole approach is beefed up. Because, you know, sometimes people say, oh, what's the point in restructuring? Are we going back to the health boards? And it's nothing to do with going back to the kind of structures in the health boards. It's about addressing that kind of the monolithic aspect of the HSE as it is at the moment, where it's very much about command and control, and where, for example, you know, if there's a problem with CAM services in South Kerry, to use a recent example, what we have is the chief executive coming on with Audrey on Morning Ireland, apologising, promising a report which we may or may never see. And like that is the centralised nature of how the HSE operates. We need to have devolved responsibility and legal responsibility to the senior management in that area. Okay, and that's how you achieve responsibility, that you give power back to management. You don't disempower them by holding power at the centre. You give power to management, you give responsibility, and you give accountability. And like, you know, we pay our managers very well. They should be expected to be empowered and to use that power properly. And there has to be consequences if they don't. And to my mind, that is absolutely critical to the reform programme that is Sláinte Care. Unless we have accountability down through the system at administrative and clinical level, like I can't see much changing. And that's why government needs to move to accept the need for legislatively based accountability, along with the restructuring that is the RHAs. So, I mean, the key elements of that is restructure to integrate acute and community services. That's critical. They do their own thing at the moment. We have to have integrated care. That is the future of healthcare. We have to have accountability. We have to have population-based resource allocation. And they're the key factors involved in relation to the RHAs. And we need to get moving on implementing that plan.
Thanks, Roisin. Some points coming in. RHAs are not being set up on a legal basis, so would you change that?
Yeah. Memo went to government last year, and basically Cabinet were given 3 options in relation to the RHAs. The first was really not do an awful lot to change things. The second was take some steps to change things, and the third was to do it fully. Now, the government opted at the time for the middle option, the second option, which didn't entail legislative-based change and accountability. I think as the department and the HSE are working their way through that, and the Health Committee of the Oireachtas attends monthly briefings with the department and the HSE, and I think they're coming to a realisation that unless this is legislatively based, it's not going to make a huge difference. And I have to say that the advisory body chaired by Leo Cairns, set up by the Minister to advise on the implementation of RHAs, is doing a really good job. Now, we can't get our hands on the advisory notes that they provide, unfortunately, but we know from the Health Committee of the Oireachtas interacting with that committee, with that advisory body, that they absolutely get what Sláinte Care is, and it has to be done properly. And it remains to be seen whether government, the Department of Health and the HSE take their advice on board, and that's really essential.
Philip.
Yeah, I mean, just maybe building on that, and building on what Stephen said earlier on. I mean, I think we all know we don't want to set up structures that are not going to be powerful, they're not going to be able to act. But equally, I guess, and I think Steve made this point very forcefully earlier this afternoon, we don't want to set up 6 mini HSEs either. We don't want to, a lot of us genuinely believe that the front line know the answers to what the front line needs. And what we need is a culture and a management approach that really listens to our frontline staff. And we do a staff survey every 1 or 2 years. And that gives us a very clear picture, and you can compare areas to areas as to how staff feel valued, are they listened to in regard to their own ideas. And we've work to do in that space. And I certainly think anything that empowers the new structures will be good. But how we all behave will be really crucial as well. Because there's even with a legally empowered structure, there's still levers you can apply to try and control. And I think the key will be how we all behave. And I think there's a very strong commitment to make sure these new structures work.
What's your view on this, Derek?
So my view on it is that clinicians are often bedside focused. That's their scope of control. And as they move further back to the ward and then to their division of specialty and so on, they can see more and more how the system fits together. The challenge is that basic things that you might need in a local service, like you need an extra nurse or physician, or like I had a clinic yesterday, for example, started at 2, finished at 7 p.m. last night. And one of the reasons it finished late was because we saw 40 patients. And then the other reason was that we didn't have a digital backbone. We didn't have an integrated digital solution for the clinic. We had to log into 8 different things. The hospital in Ballinasloe, which is 30 minutes away, I couldn't access the bloods there. I had to ring them. The pharmacy medications for one of the patients, they didn't have their list. I had to ring the pharmacy. They're the kind of practical things that everyone sees around the HSE. And to get a digital backbone is the most important thing to improve clinical delivery. And I think any clinician would know that. We might have a great heart, a great lung, great muscles, but unless you have that backbone, everything's on the floor. So I think that's really important. I think everyone knows that. The central theme today has been we need ICT, we need it integrated, we need it both in the ECC, in the enhanced community care, we need it in general practice, and we need it in the hospitals. Interestingly, the people that have it best done are the general practitioners, because they are operating as individual contractors and they have really good EHRs in their system because they have to be efficient. So I think that's one of the big messages today, is that if you were to ask any clinician in Ireland what's a pain point, workforce, physical space, but that ICT will be transformative when it actually does happen here.
Thorsten, if we look at healthcare and what it will be like by the end of the decade, what will the lasting impact of the pandemic be on the healthcare system here, do you think?
That's a very good question. I was actually learning today and wondering today if there is going to be a lasting impact, or if we peaked and now actually slowly return to where we were before. I hope there is going to be a lasting impact. If I think about the healthcare system at the end of the decade, I think it's going to be for sure 2 things. It's going to be personalized and it's going to be digitized. So I think whatever healthcare system you want to build, it needs to be able to deal with these kind of technologies. Personalized means, for example, we just started a study with so-called CAR T cells. So these are cells we take from the body of the patient. We engineer tools on top of these cells so that it can attack the tumor. We reinfuse it in the body, and then they have even the potential to cure cancer. So that's the most personalized technology that's currently available. And we want to make sure that the healthcare system is set up to deal with these kind of technologies. Most of these technologies will not be handled by one physician in isolation. It will take collaboration of different functions in the hospital, collaboration of the hospital and of the community sector. And the other topic is digitized. There was a lot of talk today. It starts with all the documentation, where the digitization can certainly generate efficiencies. But then when we were talking about the pandemic, we're thinking we knew after a while what strain would come from where. Would the vaccine still work? Do we need a booster? That's the power of data. And that kind of real-time and real-world monitoring of disease, that is something that's going to be much more applied. And if that is being applied to treatments, for example, it allows you to measure, does the treatment work or not? And then you can move to performance-based payment, which means you only pay for what works. And again, you create an efficiency. So I think this personalization and digitization, that for me are key concepts of the healthcare of the future.
And that personalization, the work on the cells that you spoke of, is our public health system currently set up to allow that to work, to function, or would that be purely in the private sector?
It's difficult. So it starts with giving the patients access, means it needs to be reimbursed. The current reimbursement process is set up in a way that it said, let's put all rigor at the entry point. So we want to see the data now, and then we want to evaluate what's the value for us, and then we negotiate a price, and then it's being accessible. With the treatment, CAR T is so individualized, and because it's small patient numbers, you have so little data in the beginning. Actually, you need to find a mode where you say, let's monitor it continuously, and let's continuously say what's the value for us. And as I said, if it doesn't work, you don't pay. So that's a different way to have a drug enter the market and then to deal with it. But it will also need the infrastructure, the monitoring, the agreed outcome parameters. What are we actually looking at? What does good look like with a treatment like this? And then maybe also have more continuous negotiation. So I think it's actually, if I think about it, a nicer, way more collaborative style to handle treatments that are in the market than we're doing today.
Roisin, listening to that, do you worry that it will only be people who are able to pay for this will be able to access this and other revolutionary treatments?
I do, because I think the problem is waiting lists and getting access and early access. And, in talking about the hangover from the pandemic and the impact of that, I mean, I think on patients, we're talking about a significant number of people who will have problems with delayed diagnosis. And I think there's two particular areas that are going to be and are very evident. I think the first one of those is in relation to delayed diagnosis of cancer. And certainly in the Health Committee, we had the Cancer Society in with us last week, and they're expressing serious concern about delayed diagnosis. I think the other area is in relation to mental health problems, and particularly in relation to young people and older people, affecting those cohorts very differently. And I think we're going to see the impact of COVID, just generally the pandemic and impact on people's lives and their physical and mental health for some years to come. And the other thing, of course, in relation to patients is the lengthening waiting lists as a result of COVID. So they're going to be the main impacts. I think there's also going to be a lot of ongoing impacts from the pandemic on staff. And I think increasingly we're seeing the impacts of burnout on healthcare staff. And that's a kind of self-fulfilling thing, because when people kind of, have come through a very stressful period, they're feeling burnout, they're not necessarily feeling terribly valued within the health system, and they don't necessarily feel that there's anywhere to go if you have difficulties in coping. I think a lot of those people will think about moving out of healthcare and moving to, sectors that are less stressful. And I think that's going to compound the problems that we have, which I think are very significant at the moment in relation to the lack of staff. I mean, we were talking about additional funding. A bigger problem than funding at the moment is being able to recruit and retain staff. And it's probably the biggest challenge facing the health service at the moment. And again, that's kind of self-fulfilling. Unless we tackle that, have good, robust workforce planning programs in place. I'm not aware of any significant workforce plan for the health service, I have to say. I've been pursuing that for some time, but in terms of, projecting out the next 10 years, what will the need be for different categories of healthcare workers? I haven't seen that set down on paper, and the implications of that for third level places and for clinical placements. And what we're seeing now on a regular basis over the last 3 or 4 years is additional funding being provided, and that's great and that's undeniable. But at the end of the year, you find out that maybe, a half or 2/3 of the expected staff recruitment that's all that's taken place, and then a very high turnover. I just want to make the point in relation to the healthcare system. I think the experience of the pandemic has given a lot of people pause for thought, because I think there were a lot of very important principles that were followed in terms of organising the healthcare system during COVID. For example, at no point could you buy your way to quicker vaccinations or quicker testing, right? What we saw was a single-tier universal healthcare system in practice during COVID. So it didn't matter how much you had. The system absolutely correctly prioritised people with the greatest health need, so older people, people with underlying conditions, got their vaccinations before kind of healthier, younger people, that kind of thing. And there was no way of getting around that, of skipping the queue. And I think they were really important principles that applied, and that we had a population-based vaccination system as well. So I think those kind of messages kind of struck home with people and, you know, made the stronger case for sláinte care in terms of universal healthcare system that people had access to on the basis of priority need. Okay.
Yeah, I mean, I think it's a very interesting kind of area because we're right at the cusp of it now, really, in terms of what do we do after the pandemic? And there's been a number of academic papers written about to regress or to transform. That's our choice. We can go back to the old ways of working, or we can continue to drive the kind of improvements we saw happening at a time when the health service was trusted, it was backed, and our staff came up with the solutions. And it was a phenomenal time in many ways. It was a terribly sad time for many of us who were affected by it and our families. But in terms of a health service workforce, strangely, we worked in a way that I don't think I've ever seen my colleagues work. I saw people work every day of every hour and never complain, every single day of the week, every month, and for 2 years, up to 2 years. And because the shared purpose was entirely clear, I think the thing that really burns people out is when that adrenaline kind of passes on, if you like, and that we go back and more to business as usual. We see business as usual has been severely harmed by the pandemic in so many ways, as been highlighted by many speakers today. And something Stephen talked about earlier on, people go back and then they find this kind of common vision isn't there. Maybe they can't get their job done. That's when people really just burn out then, because they're tired already, but they had that kind of motivation. I mean, the motivation of people, that I saw in people was just phenomenal. So I think to transform, we need to keep doing the things we did well. I think deference to expertise was a key feature of how we managed the pandemic. And David talked about whether Lucy listens to him or not. He's the expert in digital in Tala. I'm pretty sure she does, judging by David's presentation. She'd have to. So, you know, that's what we did during the pandemic. We deferred to expertise. We will continue to do that.
Derek, what's your view on the lasting impact of COVID on the delivery of healthcare here, say, over the next decade?
So I think, as David mentioned earlier, you know, it was transformative and it was led by COVID-19 primarily. You know, you can think about 10 years of digital transformation happening in 1 year in healthcare. And you have to remember that the central tenet of healthcare anywhere in the world is based on the fundamental fact of primum non nocere, which is firstly do no harm. So healthcare tends to be something that moves quite slowly, like a big oil tanker. It doesn't change very quickly its direction, and for good reasons, because it doesn't want to, you know, rapidly change and adopt something new because it might have unforeseen consequences. That, you know, philosophy makes sense, but the challenge is when it becomes a disadvantage, when it becomes inertia, and then you can't change at all. And so all the technology that comes along, it's like speedboats that change rapidly and so on, but healthcare itself has been slow. The frustrating thing for everybody, even the people who work in healthcare especially, is that all other parts of our lives, from shopping to banking, has all changed in the last decade, whereby we expect that, you know, just-in-time service and that personalized approach to the way we interact with those different infrastructures. Healthcare is starting to adopt it. If you're to look around the planet, you look at the US system as being the most advanced. One of my last rounds at Mayo Clinic went into a ward to see a patient on a morning ward round, and they said to me, "Doc, I just got my CT scan and they said there's a lesion on the liver. What does that mean?" I mean, that's transformative. You know, the traditional medical dogma for hundreds of years has been this, you know, false pyramid approach whereby, you know, the consultant at the top just talks down and tells the patient how it is. This flips it on its head, which is the way it's supposed to be, whereby, you know, the job of the clinician is to actually inform and educate and bring the patient with them. So, but it was at the Mayo Clinic because it's a pay-for system. And the challenge is bringing that technology. I mean, we can buy it off the shelf. We don't have to build it ourselves. You know, there's the Epics and Cerner systems of the world. To bring that, which is expensive, into our system, we have to do the risk-benefit. And the equation is clear, it's benefit. But we have to resource for it. We can't just talk about it and have summits about it. We need to resource it. Bring in something like that and it will transform your access to your own health information like you do your own banking. And I think that's another great analogy. Traditionally, the hub and spoke model of coming to this great center, physical infrastructure where the experts and the equipment were, that needs to change like banking. Healthcare should move to kind of like the banking approach whereby most of your banking now is digital to digital. Only rarely do you go into the physical infrastructure. Healthcare, and especially, as we said, by moving the lens back to managing and preventing chronic disease, needs to move to that approach whereby many chronic diseases need frequent interventions just to kind of correct the rudder to keep people on the middle path. They don't necessarily have to come into the hospital and so on. And there is really good innovators in healthcare trying to do that. The challenge is trying to move that ocean liner. It's akin to changing the engine as you're driving the car, but you're changing it from a petrol engine to an electric engine, which is even more difficult. So I think that the tools are out there. You just need to adopt them into our health service and do the equation with the finance.
And Derek, just listening to you there talking about your final ward in the Mayo Clinic, I was just wondering, where would you say it's better to be a patient, in the US or here?
Yeah, so that's a great question. I have a very simple answer. So it's easy to complain about the forest, which might be here, when you've never been in the jungle. And the American healthcare system is fantastic if you're wealthy. And I personally have a philosophical problem with that, which is one of the reasons I came back to this jurisdiction, because I believe that the healthcare system you have reflects your society. And I think that our goal is a noble one to strive for a public health system. I think that's the way it should be delivered, that reflects our society. You have to choose whether you want Boston or Berlin. There's no doubt. There's actually a great book called In Search of the Perfect Healthcare System. And in it, at the end of the book, the answer is that there is no perfect system. The US have the best technology in the world because it's paid for. It's funder paid. The Europeans are more the community public health model, and there's massive underfunding accordingly. So you have to decide what your society wants. I'm proud that I'm in Ireland and we have our public service and our public healthcare system. Certainly during the pandemic, I was delighted to be in Ireland as colleagues in the US were ringing me, asking me for PPE. And they just didn't have any because they didn't have the infrastructure for people, wasn't set up. There's massive inequalities over there. So I'm very happy to be in the forest. Is it perfect? No. Are we making a plan to make it better? Yes. Are we putting the resources in there? With Slontacare we've heard and I've seen, I'm the new lead for diabetes. We have thousands of posts put in place for the community services. So we're improving, we're getting better, and it's much better to be in the Irish system if these are the values you believe in. So I'm sure everyone in this room believes in those values, or they'd be in the States, or they'd be in Australia or somewhere else.
Well, look, I think on that positive note, we will leave our discussion for now. We're at the end of our Health Summit, so will you please thank our panel.